With this lecture, we're taking a look at neoplasia, or the formation of cancers. Our focus is primarily on the cell, although we will take a look at some of the characteristics of actual tumorous growths. We begin by just taking a quick review of the cell cycle. You can go back into, I think it's chapter 4, pages 74, 75. We'll take you through the basics of the cell cycle. I'm not going to ask you won't see this diagram or ask you about the components or parts of the cell cycle within the exam. I only bring this up to kind of remind you of this process, and really this final point here at the bottom. Our normal somatic cells, or the normal cells of the body, spend about 1/5 of their time in mitosis and about 4/5 of their time within the other phases. So in other words, our cells are not continually always dividing, and of course there are some cells that move into that GO phase and they're in an active state in terms of the cell cycle. Our muscle cells, for instance, are in this phase. These cells do not divide. Unless there's something abnormal going on, we'll see some hyperplasia. But for the most part, we do not see growth within the muscular cells. And so they actually move out of the cell cycle altogether. But for thinking about epithelial cells, connective tissue cells, other tissues within the body, they move through this cycle, spending a relatively short amount of time actually dividing. Cancer cells, or neoplasms, are just the opposite. They spend the majority of their time dividing, hence the problem with growth of cancers. So that's really what's important here. Do take a look back on 74, 75 if you don't remember any parts of the cell cycle. I may refer to it in questions on the exam, but I wouldn't specifically ask you something about this cell cycle, except again for this final point. There's some terminology that you need to know with regards to cancers and neoplasms, so please take a look at that handout. The definitions are there, and bring to my attention anything that you have a question about or the terminology that doesn't make sense to you. But a lot of that terms actually do link back to some basic A&P concepts as well, things like the stem cells, permanent cells, stable cells, that sort of thing. So do take a look at that. And then also, I want you to know some of the types of neoplasms. So table 7.1 on page 131 in your textbooks lists some benign tumors and some malignant tumors, and then the type of tissue that's involved there. So on our slide right here, that information is left blank. What I want you to be able to do is go to that table, take a look at just these 4 types of benign tumors, and then here you have 6 types of malignant tumors, and then what type of tissue is involved with each of those different types of tumors. Benign, remember, again, if you haven't looked at this terminology at all, benign tumors are non-cancerous tumors. They are abnormal growths, but they are not cancerous tumors. And we'll take a look at the difference between benign and malignant in just a moment. But I put this slide up here early so that you take some time, go look up the types of tissues and be certain that you have this is pretty much a pure memorization. You're going to hear a lot of different types of cancerous tissues mentioned throughout your career. These are some of the most common ones, and certainly aren't all of them. But I didn't want you to have to know that entire table, just the parts that you see here on this slide. Alright, so let's take a look at the difference between benign versus malignant tumor. So again, as I mentioned, benign is not non-cancerous. It can cause problems. So don't think that everything that's benign is just, oh, no big deal. Benign tumors can get rather large and can get in the way of things. They can block blood flow to an area, impede nerve stimulation. So there are problems with benign tumors, but the characteristics of them are different. First of all, if you look at the picture we've got here, benign tumors stay local. They do not spread. So although they can get large and push into areas that are adjoining, they will not break off and spread to other areas. So one of them is the fact that the cells itself do not split off, do not spread, do not invade tissues beyond their area. They grow much slower than you would find in a malignant tumor. And the term metastasize, where they would actually spread to areas elsewhere in the body, does not apply to benign. So when you look at a benign tumor, they grow slow, they stay local, they don't really invade other areas. They may push against it, but they really aren't growing into other tissue. Malignant tumors, on the other hand, absolutely invade. They grow much faster, so they can have what we refer to as local invasion. Local invasion is they're spreading within the tissue of where they're at. And they can also metastasize, where they can go to different areas. And we'll talk a little bit more about metastases in just a moment. But those are the two main differences between benign and malignant tumors. Now, these are cell characteristics of malignant neoplasm. So now we're really down at the cellular level. In that previous slide, we were looking at the difference between the types of tumors, the masses of growth. But here we're looking at what are the actual cell characteristics of malignant neoplasms. Real important concepts here. I'm going to go through each one of them kind of quickly. They're all covered in the textbook as well in the reading. So you may want to take some of this down and pause this lecture. It's real important. I'm going to ask you about these, and there's some application that goes to this. So, first characteristics of malignant neoplasms is they all have altered DNA, or what we would refer to as genetic instability. What that basically means is that they have one of the terms or terminology that you have on the list is aneuploidy. That's a genetic instability or an abnormal number of chromosomes. So aneuploidy is the chromosome number is off in there. So there are definitely going to be mutations that go on, and a cancer cells, a malignant neoplasm, can actually mutate within itself. So it can be a mutation in the first place, and then its cells can continue to mutate, continue to have differences in the chromosome numbers. The second thing is that there's a loss of differentiation. Normal healthy cells are very specialized to particular functions. They differentiate into stomach cells or into intestinal cells and liver cells, if we're saying, within the GI area, or if we're looking in the brain, there are going to be specific cells of specific areas. The cells of the hypothalamus will look different than the cells of the basal ganglia, and so forth. So they differentiate, become specified to their function at their area. Malignant neoplasms lose that differentiation. They start to move away from what they originally came from. So all cancer cells, all neoplasms begin from something normal that has mutated. That mutation then starts to lose the function. It no longer behaves like a brain cell or a stomach cell or a pancreatic cell. It starts to lose its specialization. The function it's supposed to have, it no longer has. Increased cell division, we mentioned that earlier as a characteristics of malignant tumors. Well, therefore that applies as well to the cellular level as well. They proliferate very rapidly. They divide. So there is loss of differentiation, they're not specific, and they proliferate. So that's the characteristics of the cancer cells. Then we have what we refer to as altered contact inhibition. In normal tissue, cells recognize a stomach cell is forming, say we talk about from fetal development as the cell specializes and becomes a stomach cell. That stomach forms itself, and it does not start to invade and grow into the pancreas or the spleen that are sitting right next to it, or grow up into the esophagus. It recognizes that, hey, I'm a stomach cell, I stay here, and that's an esophageal cell or a spleen cell, and I don't grow into that tissue. So that contact inhibition is that as one cell comes in contact with something else, it recognizes that's not me, and I'm not my kind of tissue, and it stays contained, and therefore a stomach becomes a stomach. Likewise, even within, you have all your organs formed once you're born, or nearly everything is as formed as it's going to be, and it just gets bigger. Well, as things grow, they also recognize I won't grow into other areas. So as you add more tissues and more bones and so forth, and as things that expand and grow as you develop, they recognize I don't grow bone into the muscle tissue that's adjoining it. It stays as bone cells, and so that division doesn't take off and go odd, unless of course it's cancer. With cancer, the contact inhibition is altered or lost, and it no longer recognizes that other tissue is not me, and it simply grows right into it. That protection, that signaling that kept it from growing into other areas is gone. And so now, with the lack of contact inhibition, what you actually have is it doesn't sense the joining cells as being different, and it grows right into it. So if I look at our previous picture here, you see how it's growing into here. Normally, even in a benign tumor, it recognizes, hey, that's not me, and it doesn't grow any further. Cancer cells, neoplasms, they absolutely know, have lost their, and they don't care. They don't care if you can give it a personification. It doesn't know or care. It simply grows into the next area. The next thing is loss of cohesiveness, and this is linked to this idea of contact inhibition. Cells also cling to each other, so stomach cells stay attached to stomach cells, and again, I'm being very vague with that, but the epithelial tissues, the connective tissues of the muscles, all that make up the organs, they cling to each other. There's a cohesiveness. There are connections between cells that make them into tissues, that make them into organs. Cancer cells lose that, and that really is how you have the spread of cancer to other areas of the body. The cells literally break free and move off, whether it be through lymph tissue, blood, other fluids, mucous membranes, and so forth. They move to other areas because these cells break away and continue to divide. Nothing's there to stop them from dividing. And so that loss of cohesiveness causes cancer cells to break away. Impaired cell-to-cell communication refers to the fact that organs and structures communicate with each other. They share resources and they work together as a unit. That's how an organ, tissues or cells become tissues, becomes organs, and they work together through cell-to-cell communication, cell signaling. That's impaired as well in cancers. For that reason, that's why cancer cells that break away can keep on dividing. They don't need to communicate. They don't rely on each other. They just grow and divide very haphazardly and very destructively, grabbing all resources it can get its hands on. It's kind of like a virus. It takes advantage of things. Cancer takes advantage of all things, grows where it wants to grow, does what it wants to do. And then finally, they are immortal. In Chapter 2, we talked very, very briefly about the enzyme telomerase. Telomerase was the enzyme that added, when a cell divided, recall the telomere was the end of the DNA chain, that last piece that needed to be reattached in order to maintain the lifespan of the cell. Well, cancer cells have extremely high levels of the enzyme telomerase, and so they never get old. They don't die. They just keep dividing, making more and more. So, very important characteristics of cancers or neoplasms. Please be sure that you understand that, because I may give you a scenario in which there has been an invasion of cancer, and I ask you to tell me 3 or 4 reasons why that would have occurred, and I'll need you to refer back to these processes. So really important that you understand that. Alright, so then how does cancer spread? This is really building off that lack of cohesiveness, lack of communication. We have 3 terms that we use in terms of how the cancer spreads. One is direct invasion. That's what our picture back here really looked like. That's direct invasion. It just, if you have cancer of the stomach, it may spread to the pancreas. That's right next door. It's direct invasion into adjoining tissues. It may do what we refer to as seeding. Seeding is similar to metastatic spread or metastases, but we're going to kind of differentiate them. Seeding is when the cancer spreads within the same body cavity. So if you have cancer of the stomach and it becomes cancer of the large intestine, maybe the ascending colon or the possibly rectum, we're starting to get a little bit more into the pelvic category, and that might be a little more than seeding. although that is one entire cavity. It's pretty far apart. But again, so if stomach cancer spreads to the liver, the gallbladder possibly, where it doesn't have direct contact with it in particular. Seeding is where the cells break free, but we're still really within the same body cavity. Metastatic spread, though, is when we leave the body cavity, we go to different areas. So for instance, bladder, and our examples of some of the main ones, and you do not have to have this list memorized at all. This is just for example. But if you have cancer of the bladder, and again, this is going to be referring to the urinary bladder. If you have cancer of the urinary bladder, it commonly metastasizes to the bone, liver, and lung. Technically, we would put all of those in slightly different bodies. This is certainly thoracic cavity. This is outside the body cavities in general. Liver is still within that abdominal pelvic cavity, and that's really one big cavity, but it's pretty far away, so you can use that as a metastases. Lung cancers, adrenal gland, bone, brain, liver. The other lung, technically within the same body cavity, but again, depending upon the distance it might be, that's kind of a little bit between spreading or seeding and metastatic. I don't make a huge difference between the two, although I'd like you to be able to define the difference. I wouldn't ask you, for instance, if I said from one lung to the other, in my definition, I'd probably call that more seeding than metastatic. But I'm not going to give you a question that's so vague like that. And then down here at the bottom, exclusive primary sites. This refers to areas where really what you have is cancer will originate there, but it does not usually spread. Usually, and I guess I thought it was at the bottom of the slide. I guess I don't have them actually listed here, and I apologize for that. Primary sites are where the cancer originates there, but cancer doesn't spread to these areas. In other words, you won't see metastases to these areas, and there are basically three areas: the heart, the skin, and the skeletal muscle. So I apologize, they're not actually on my slide. Heart, skin, and skeletal muscle. These three areas very, very rarely have cancer that spreads to them. So you can have cancer of the heart, but it started there. You can have skin cancers generally begin there. Cancers don't spread to the skin. And skeletal muscle, very rare kinds of cancer that affects skeletal muscle, but you do not see cancer spreading to that area. The reasoning for that is pretty unclear, particularly when we start talking about something like the heart. But good for us, because cancer spreading to the heart would be really always fatal. So, but there is such a thing as heart cancer that can occur. Etiology, or the cause of cancer, we really look at two things. We look at environmental or host factors, and we look at genetic factors. So starting first for a moment at the host or environmental factors, your book, pages 141 to 144, go through some of these. They are things like excessive hormones. They're health issues like obesity, use of carcinogens, smoking, for instance, tobacco use. It can be chewing tobacco. Radiation, that would be exposure to a large sun. If you lay out in the sun all the time over the years, you're at higher risk of developing skin cancers. There is some linkage between viruses and bacteria. We have identified a few that makes tissue susceptible to cancer development. I don't know that I don't want to get out there and start saying viruses cause cancer. We talk about the HPV virus leading to higher risks of cervical cancer, and that is absolutely the case, that the risk factors increase. But are they the direct etiology or cause? That's still open for debate. But there are a number of things. So take a look again, pages 141 to 144. But what we really are going to look at a little more closely here at the end of this lecture is the genetic causes of cancer. And so that's where you're going to see greater questions or more complicated questions on the exam. And so we definitely have issues with genetic problems. Now, be careful, because genetic doesn't mean hereditary. There are definitely cancers that can be inherited, and they're linked to genes, but all cancers have to do with some sort of genetic mutation. So even if I'm back here looking at these viral problems, or these environmental problems, rather, viruses, radiation, and so forth, they all affect the DNA. They all affect genetics. But so there's a difference between affecting the genes and then having it be hereditary, where you've inherited it. So be careful with that concept. All cancers are related to some sort of mutation that's linked to genetic problems. But we have two main ones, and these are not all of the things that can go wrong with the genes, but we have two main categories that we're focusing on. So we either have genes that are involved in overactivity, and in a moment you'll see genes that are involved in underactivity. So our first thing we're looking at is what we refer to as proto-oncogenes. So the proto-oncogene is the normal gene that codes for normal cell proteins that promote cell growth and cell signaling. Let me say that for you again. Proto-oncogenes are normal genes that code for normal cell proteins that promote cell growth and cellular signaling. So they're the good guys. Okay? But they become oncogenes when there are mutations to them. So a proto-oncogene becomes an oncogene when it's been mutated, and then what you have is uncontrolled growth. So this is genes that cause overactivity. So a proto-oncogene, if it works normal, it's controlling growth and function. But when it's mutated and it becomes an oncogene, then you have uncontrolled growth. All the things it was supposed to be doing with regards to cellular signaling and growth gets completely out of hand, and you now have massive growth. So mutations to proto-oncogenes are one of the things that lead to this massive growth, and with the massive growth there are often then mutations associated with it. So that's there are lots of different kinds of proto-oncogenes. So this is a category of genes. And then you have the genes that are going to cause underactivity. So we have what we refer to as tumor suppressor genes. These are normal genes that protect against activated or newly acquired oncogenes. So a tumor suppressor gene is a good guy. The tumor suppressor gene is out there to try and stop uncontrolled growth, stop those oncogenes from functioning. There are multiple of them, but I have one tumor suppressor gene, the p53 gene, that I want you to know. And that gene is often referred to as the guardian of the genome. It's one of the most common target genes for genetic alteration. In fact, almost every kind of cancer can have, doesn't always, but can have a mutation in the p53 gene. So p53 is a tumor suppressor gene. Its job is to control growth. But if it gets a mutation, because you're going to have some oncogenes that if you may have them, they form, but you've got the p53, it's out there keeping everything good and safe, and it never actually gets out of control, which just sends the proteins out to kill it. But if you have a mutation in the p53 gene, then you have a problem where you no longer have the ability to stop that growth. So it's the guardian because it's protecting you against oncogenes. It mutates and it no longer can no longer protect you. So technically what it does is it looks for or senses DNA damage in cells, and actually as the cells in the cell cycle in the G1 phase, it actually can hold it there and say, I won't let you divide any further. So that's really what it's actually doing. So it also initiates apoptosis. So p53 gene can take a look at a cell and go, you're not right, I'm not going to let you divide anymore, and actually I'm going to initiate from that extrinsic process, I'm going to initiate apoptosis and kill it off. So that something goes wrong with that gene and you no longer have that process to protect you. Tumors that retain normal p53 genes. So because it is possible that you can still have a cancer and the p53 gene is normal. Be sure you understand that not all cancer, there's so much variety in the way cancers form. But we take a look at the p53 gene, and if a cancer exists, but we look at the p53 gene and it's still normal, you have a much better prognosis for your response to radiation and chemotherapy. So even if cancer kind of got whole, but the P53 gene's still good, you are much more likely to survive your cancer in most cases. If the P53 gene, however, is defective or has a mutation in it, you will not respond as well to radiation and chemotherapy. So, important genes. Oncogenes, the cancer causers, the proto-oncogenes are the good guys that have been mutated, and then you have tumor suppressor, specifically the P53. All right, just a little bit on systemic manifestations of cancers. These are also covered in your book. Now, the table 7.3 is going to list something called paraneoplastic syndromes, and I've written that out for you here, but let me just first talk about the first couple of terms. Anorexia refers to a lack of appetite. So don't think of anorexia nervosa, the eating disorder. This still is associated with eating, but it's an absolute lack of appetite. So it's not a psychological disorder. This is a actual physiological condition in which the patient lacks any appetite or any desire for food. It can be occurring because of the treatment. So anorexia will occur if you're in chemotherapy or radiation, depending upon what area is being radiated. There may be a loss of appetite. Cachexia, however, refers to a weight loss and wasting of body fat and muscle tissue. That actually occurs with most solid tumor cancer. So again, not necessarily in a leukemia, although it can, but most tumors have a cachexia associated with it. One exception, however, is breast cancer. Patients who suffer from breast cancer, even if the breast cancer is metastasized, if it's still fairly early in the metastases, and it does depend on the area, you don't generally see cachexia. You don't see that weight loss and wasting of body fat and muscle. We actually see this also in HIV patients. Cachexia is not a term that only belongs to cancer, but many cancers do have this going on. There are also fatigue and sleep disorders that are associated with cancers. Again, sometimes it's the cancer itself, and sometimes it's the treatment for the cancers. So with all four of these, they can kind of go into both the cancer itself. A lot of times that's what leads to a diagnosis. I'm just so tired and so fatigued, I have no appetite, what's wrong with me? And you go in and you discover you've got a tumor in your lung or tumor in the stomach or whatever. But sometimes they are not existent until the treatments begin. And then finally, paraneoplastic syndromes. This is an interesting concept, and we'll talk a lot more about paraneoplastic syndrome when we look at lung cancers, because we'll identify some specific ones. But this is where cancers start producing something. A lot of times that something is a hormone that actually doesn't have anything to do with the tumor itself. It just starts producing this hormone, or a cytokine, a chemical in the body that is usually actually produced someplace else. And for instance, in a lung cancer, you may find that with a lung cancer, some of the tumor cells in the lungs start producing the hormone ADH, or antidiuretic hormone. And the function of ADH is to retain water. And so this patient starts having a lot of fluid issues, a lot of edema that's going on. And they go to the doctor because they're swelling up all the time. And they can't figure out why, and in a relatively simple test, they determine that the ADH, or vasopressin, antidiuretic hormone levels are really high. And really, many physicians know this is an indicator of lung cancer, especially if you have the fairly early stages of lung cancer. It's a good way to diagnose it and possibly save your life. So paraneoplastic syndromes aren't always bad. They cause something else to happen, and they're occurring, and they help you diagnose your cancer earlier. There are others that affect calcium levels, there are blood clotting issues. So these cancer cells start producing some product, hormone, chemical, that isn't normally something we would see that tissue. If it's lung tissue doesn't ever produce ADH or PTH. That's not normal at all. There are no hormones being produced there. But suddenly those cells start producing that, and those levels go all out of whack in the body, and that's an indicator, hey, there's a tumor somewhere, we've got to go find it. So that's the idea of the paraneoplastic syndrome. They're listed on table 7.3. For this exam, in the paraneoplastic syndrome, I just want you to be aware of the concept, the definition. You don't need to know anything specific yet. And then when we get to the end of the course and we look at respiratory disorders and lung cancers, we'll come back and revisit that. So that should take us then through the systemic manifestations. And then the final piece here is how do we stage and grade tumors. Staging is going to be unique to the particular cancer. So some cancers have 4 stages, some have 6, some have 2, some have 3, and so it depends upon the cancer. A lung cancer may have 6 stages. Lymphomas generally have 4 stages, and so these are some of the things that determine the stage. How big is the tumor? Did it invade other tissues? Is the lymph nodes involved? Is the bone marrow involved? Has it metastasized to regions outside of the, if it was lung cancer, is it now in the brain? Well, that will take you to a further stage than if all of the cancer is contained in one area. We don't see it in any lymph nodes. We don't see it in any bone marrow yet. So staging depends. It's usually 1 through 6, and sometimes it's different numbers. So staging is unique to the cancer itself. So there's no universal staging for cancers, but these are the characteristics that are looked at. Grading, however, is what we do to look at the characteristics of the cells themselves. So this is what the pathologist looks at. The pathologist looks at it and says, all right, how close is the cells to the actual original tissue? So if I have lung cancer and they try to cut it out and remove the tumor is sent to the pathologist, and the pathologist looks at it and grades it and says, well, if it's a level 1 or 2, that means that it is actually well differentiated and closely resembles normal cells. So if it is a 3 or 4, it is starting to look very different, and so it's going to be more difficult to treat. The higher the number, the more abnormal it is less likely to respond to treatment. Right? So cancers that look very abnormal, they tend to grow very rapidly, producing chemicals, metastasizing very quickly. They're going to be the worst types of cancer and more difficult to treat. So lower numbers, those that are more similar to the cells they began from, are easier treated. And so a lower grade is a better response in terms of how well the cancer will respond to the various treatments, chemotherapies, or radiation. Okay, that takes us to the end of the neoplasms.